Yeah.
Good evening, everyone. Welcome to Classroom Series. So today we have a topic by Dr. Bharat sir. He's an associate professor in NIMHANS, Bangalore. The topic is hemodynamic optimization in neurocritical care. As we know that in neurocritical care, different types of cases come. For example, in trauma cases, the hypotension has to be managed in a different way with fluids and blood products. Whereas in subarachnoid hemorrhage, patients can have Takotsubo's cardiomyopathy, and that has to be managed in a different way. And also neuromuscular disorders, we have a lot of autonomic disturbances. The patients have a lot of autonomic disturbances, which again have to be managed in a different way. So each type of patient has to be individualized and treated. So Dr. Bharat sir will be giving us an idea as to how to go through with it. Over to you, sir.
Uh, Thank you, Dr. Sindhu, for that kind introduction. So, good evening, everyone. Today, I'm going to speak on what is hemodynamic optimization in neurocritical care. Now, if you see among the many goals which we have in neurocritical care practice, one of the most important is blood pressure management. And it is not as simple as to say avoid hypotension, because as we know, both hypertension, and normotension in itself, when you should have a little higher pressure in itself, would be detrimental to the brain. So, how we manage a normal brain and how we manage an injured brain are different. So, let's start. So, I have no disclosures to disclose. So, to keep it interesting, I'll just start with a common scenario which all of us in our neurocritical care practice would come across. We have a 64-year-old gentleman who is a known hypertensive, who has presented with sudden onset headache and altered sensorium. His GCS is 9, and he has a right-sided weakness at presentation. So these are his scans. As you can see, we are having a bleed in the left sylvian fissure, along with the subarachnoid hemorrhage with basal cistern showing blood. And his CT angio has shown an aneurysm in the MCA territory. So right now, his WFNS grade is 3, and his modified fissures grading is 4. Now, this patient has undergone surgery for the same, where clipping has been conducted. As you can see, he had a variable course where blood pressure has fluctuated throughout the intraoperative period. This can be due to hypertension in itself or the release of the pressure after the craniotomy is being done. And there have been phases where the blood pressure has been increased. This could be by the use of noradrenaline was needed vasopressor he has required during the intraoperative period to push the blood pressures high. Later on, maybe possibly there has been a rupture, and there has been a shock. There is a drop of blood pressure. Again, it has been pushed up and resuscitated. So this patient has had a zigzag course. You see, all the way the blood pressure has fluctuated up and down throughout the intraoperative period. Now, there's a lot of important questions we need to ask whenever we deal such patients. Here it is an injured brain. As we know, he has a poor grade SH. And here is a picture of his intraoperative phase, where after craniotomy and dural opening, we see brain bulge evident. And it is also from his postoperative scan, it is evident that after clipping, they are not able to put back the bone because the brain was bulging outside. Now, such a patient comes to only the most positive point is the aneurysm has been secured well. Now, the question is, in the intensive care, how much pressure or how much of cerebral blood flow we need to maintain. Now, this is an extreme situation which I have put forth in front of you just to get an example of what we deal in our ICUs. But it can be as mild as a common stroke patient coming in, or a post-traumatic brain injury patient coming to ICU who may not have such severe injuries. In all of them, we need to make a decision with respect to how much of pressure or flow we need to maintain. So, an overview of what I'm going to go through today. One is how how much we have to be worried about cerebral hypoperfusion. It is not just hypoperfusion which we are interested about. We are also interested about the oxygen delivery which is happening to the brain. And important concepts, just to touch upon the basics in terms of how the cerebral hemodynamics interact, and how an healthy brain and an injured brain differ in terms of the how we need to look at in terms of cerebral hemodynamics. Next, what choices we have at bedside for hemodynamic optimization. And last, we look at the clinical practice. Specifically, because I cannot cover many topics, I have concentrated on two important ones like subarachnoid hemorrhage and TBI in this group. But the once you get a hold of all the principles involved, for you, depending on the diagnosis and the pathophysiological time point, you can decide for yourself what would be the best lines of management of the hemodynamics. Now, this is a common picture which I show whenever I am trying to give you an idea of what is cerebral blood flow in a normal brain. So, the main determinant of cerebral blood flow is one is the cardiovascular system. The next is the as the brain is enclosed in the skull, intracranial pressure is another predominant determinator of how much blood flow happens in the brain. Third, but not but a very important part is the autoregulation of the brain. Now, which component of cerebrovascular system do we monitor? Now, the commonest denominator which we have in most of our guidelines is the use of mean arterial pressure. But always remember that mean arterial pressure is not a is a derivative. It is a derived marker which is determined by the cardiac output and what is the systemic vascular resistance. So these variables per se, cardiac output is depending again on the heart rate and stroke volume, and cerebrovascular resistance is determined by the whatever is the vascular tone of the blood vessels. So these determine the mean arterial pressure. So mean arterial pressure is a surrogate of the cardiac output and systemic vascular resistance. And from you, the if we subtract ICP, intracranial pressure, which would act against the flow of blood to the brain, then we get what is called as a cerebral perfusion pressure, which is determined by mean arterial pressure minus intracranial pressure. So most commonly, we are worried about cerebral perfusion pressure. If you say TBI, we would say keep a cerebral perfusion pressure of about 60 millimeters of mercury. But you have to remember that our journey doesn't end at cerebral perfusion pressure. We also have to look at how the cerebrovascular resistance is. If there is a very high resistance, then the cerebral blood flow will be less. So with this high resistance is commonly seen for us as an example would be vasospasm in subarachnoid hemorrhage. You will see a very high cerebrovascular resistance, which acts against cerebral perfusion and reduces cerebral blood flow. But our goal to provide enough perfusion and oxygenation doesn't end at that. We also have to look at what is the arterial oxygen content, which would in turn be dependent on the hemoglobin, how much is the PaO2, whether the person's lung is fine. This is also a very important determinant which we have to keep in mind in terms of providing the brain with enough cerebral blood flow. Next, but not other important consideration is what is the cerebral metabolic rate. Now, why the cerebral metabolic rate also is important? Because if somebody is having very high activity, like in terms of seizure, patient having fever, acute inflammatory states of any acute brain injury, in all of them, the requirement would be higher. So, this is also another determinant of whether the blood pressure or the flow, which cerebral blood flow, which we are maintaining, is adequate or not to your brain. So this is a summary to summarize. So the important determinant of how much blood flow happens to the brain is not just the cardiovascular system. We have to also consider the ICP, the autoregulation, and the oxygen content which is happening, which is there in the blood in order to determine whether the cerebral blood flow is adequate or not in a normal brain. Now, just to iterate a simple concept of cerebral autoregulation. So if you see, this is a common curve which you would have learned as basics for cerebral autoregulation. What autoregulation means that over a blood pressure change of 50 millimeters of mercury to 150 millimeters of mercury, the cerebral blood flow is kept constant by the change in the diameter of the cerebral blood vessel. So when the blood pressure comes down, the cerebral blood vessels dilate to maintain blood flow. When the blood pressure goes up, the cerebral blood vessels constrict in order to reduce the blood flow. Now, this is what is normal autoregulation, or this is the autoregulatory plateau. But beyond this range, less than 50 millimeters of mercury, the brain doesn't compensate enough. When the blood pressure falls below that time you would see hypoperfusion happening. When the blood pressure goes beyond a certain point also, there is no further autoregulation which can maintain the same flow. Blood flow will increase. This is a simple concept which is normally what we are taught. But is that all? If you see, there has been changes and in our understanding of what cerebral autoregulation is. and this plateau is not this wide. The plateau is much narrower. The blood pressure, the brain is, the cerebral vasculature is able to maintain a constant low over a very narrow range, and the lower limit of is much more variable. What it means is that it is not 50. As the brain gets injured or the age of the patient changes, the autoregulatory limit is might be much higher. This is what it means. But one better part is the upper limit is not very unclear, and it is seen that we are able to tolerate blood pressures which are higher better than a lower blood pressure. This is what we have to keep in mind when we look at cerebral autoregulation in in the brain. But what will happen when the brain is severely injured, which happens with TBI or early stages of subarachnoid hemorrhage? Then the cerebral autoregulation becomes passive, or it is called as pressure passive. That means as the blood pressure increases or decreases, the cerebral blood flow will linearly reduce or increase. This is the state which is the most dangerous, where we have a very narrow range where we have to maintain the pressures. Below that, you would find there is hypoperfusion, and beyond a certain stage, there can be hyperperfusion and hyperemia. So this is important for as a concept which we need to understand. Next is that the once a brain is injured, it's not like always the pressure will remain passive and always we have to maintain a very narrow range or we have to maintain very high blood pressure. It doesn't stay constant. That the pathophysiology of the each injured brain is slightly different. So this is a common example which I show for traumatic brain injury. Immediately following injury, in the first few hours, what it is seen is there's a phase of intense vasoconstriction. In this phase, what is the brain is suffering from hypoperfusion, which has to be corrected by avoiding hypotension, trying to maintain normotension would be the main goal. Following this phase, there is a phase of recovery. In this phase of recovery, what is commonly seen is there is a phase of hyperemia. That is, there is increased blood volume or the compensatory overdilatation which happens. During this phase, any hypertension can result in hyperemic changes in the brain. And vasogenic edema can also lead to increase in ICP. And following this, there will be a long third phase where the cerebral blood flow slowly normalizes to normal or below normal, and sometimes they suffer from a vasospastic phase in this third phase. So this is a example of a timeline which happens like first to 1 to 2 days, 48 hours. There's a phase of hypoperfusion where we have to maintain normal blood pressure, where there is loss of autoregulation and microvascular dysfunction. Here, maintaining a normal blood pressure would be the highest goal. Whereas in the second phase, where there is a phase of hyperperfusion, where increased blood volume is commonly seen, here keeping a control of the hemodynamics would be the main goal. Followed by a third phase where there is vasospasm, where you would try to maintain normal obstruction. So in this phase, phase two, if you have very high blood pressure, it should be counterproductive. Whereas in phase one, having a better, higher pressure would be productive for a patient. So these kind of changes do happen in the injured brain, and we need to have an idea of how and what changes are happening in a particular patient. Other than this, this is a common diagram which is commonly seen for to describe the interaction which happens following brain injury. So the brain has various vasomotor sensors, autonomic centers, which are present along with the hypothalamus pituitary axis, which control the overall state of how our heart beats. So whenever there is injury to the cortical structures, which can affect the heart in three ways. One is directly due to the neural influence; they can lead to arrhythmias. They can cause a lot of parasympathetic dysfunction, which would seem in that along with catecholamine release, we would see a sympathetic hyperdrive, which is commonly seen. And this catecholamine release would result in microvascular dysfunction along with transient coronary spasms, calcium overload, unchecked inflammation, and also severe pulmonary and systemic vasoconstriction. So these multiple mechanisms lead to myocardial dysfunction, which would come to us in the form of changes in ECG, where STT changes, prolongation of QT interval have been well described. They can also have regional wall motion abnormalities, which can be global or only apical. Then it would lead to something like a Takotsubo cardiomyopathy. And as a result of all these changes, you would see significant hemodynamic disturbance where you would find hypotension or hypertension or hyperdynamic circulation. All these are commonly seen disturbances. So, brain injury per se would lead to all these changes. But what you have to remember is, like if we do a troponin I following looking at STT changes in these patients, there might be some mild elevation which would be seen. But essentially, the coronaries will be normal, and these myocardial dysfunction would get controlled or corrected when you correct the brain injury. Like if you relieve the brain injury by doing ICP management or doing surgery, this would in turn correct the myocardial dysfunction. But then the recovery of this myocardial dysfunction is not very, like it's not like you did surgery and within the one or next 1 hour or 5 to 10 minutes it would get corrected. Depending on the amount of damage, the recovery might also take time. That's where you have to manage the hemodynamics well in order to better optimize both coronary circulation and also the cerebral circulation. Now, just to look at what parameters or choices we have when we are managing these patients. Commonly, we manage heart rate, we manage blood pressure in terms of using invasive blood pressure. Then we use central venous catheters. We can measure the central venous pressure. And one of the common indicators which are bedside used is the adequacy of urine output and electrocardiogram. Now, I don't think I need to emphasize the limitations of all these things, because blood pressure is just a number when you treat it on the monitor, which is good for a nurse to give you feedback with respect to how stable this patient has been. But then, is that enough in terms for us to say the brain has got enough blood flow? This is very difficult to take that number. Central venous pressures have multiple limitations in terms of the access, the position, and which whether the patient is paralyzed, non-paralyzed. Urine output is a major issue because not just the renal blood flow determines urine output, it also the hormonal status in terms of patients we have. We use diuretic agents during our routine practice with mannitol, or the use of patient having suffering from any sodium disturbances like SAIDH, cerebral salt wasting. All of these will affect urine output dramatically, and these cannot be used as a reliable marker at bedside to say we have maintained adequate hemodynamics. So that's where there is a role for use of advanced hemodynamic parameters like assessment of preload, assessment of afterload, contractility, and end organ perfusion markers. Now, which of these markers can be utilized at bedside or which are easier to do? Like if you have an ultrasound, I think everyone would be able to use IVC or SVC collapsibility or variability. This is a very common way of looking at the preload. Uh, or if you have placed an arterial invasive line and if the patient doesn't have any spontaneous efforts and you have adequate tidal volume, then you can look at the systolic pressure and pulse pressure variations. And if you have advanced cardiac dynamic monitors where cardiac output is being seen, then you can get the end diastolic volume or the intrathoracic blood volume or stroke volume variation. So the advanced parameters are more reliable because they measure directly from the stroke volume, whereas these have the limitations. But then the main advantage of ultrasound is it's just there at the bedside. You do not invest anything additional, and you will be able to do them at bedside. For contractility, if you do an echo, you can look at how the contractility is directly. But then that variable is difficult to, it's becomes subjective. So objectively, you can measure them by looking at dp by dt or stroke volume or cardiac output from an advanced cardiac output monitor. Afterload parameters like systemic vascular resistance or dynamic elastance are provided by few of the advanced monitoring techniques which we can utilize. We'll just go through which techniques are available. But at the end of it, whatever you maintain preload, contractility, afterload, whatever changes you have done, you always have to look at whether the end organ perfusion is good. The commonly used end organ perfusion markers at bedside is the use of lactate levels in the brain in the blood to say the perfusion has been good. The other ones are the extravascular lung water, what is the delta CO2, what is the regional saturation of oxygen, and in cases where there is a parenchymal probe, when we can look at tissue oxygenation of the brain too. So these are the various things which we can do at bedside in order to optimize the hemodynamics. Now, I would say one of the best ways to look at the heart, whether it has been functioning adequately or whether we have maintained adequate cardiac index, is to do a transthoracic echocardiography. This is an image depicting the IVC collapsibility. You can get the ratio of this in order to determine whether if the collapsibility is above 50%, then we can give more fluids or maintain a more positive fluid balance. We can look at contractility by looking at shortening or even ejection fraction. And if it is less, then it would indicate the need to start a contractilizing like dobutamine. Also, how much of diastolic dysfunction can also be seen. And you can get a numerical value if you get the velocity time integral of the LVOT, then we will be able to calculate the cardiac output. So this only thing is learn is in the important thing. It has a learning curve. But if you are able to do this, is a ready bedside measure which is available for you to look at the cardiac output status. But the main limitation is that you have to be there to do, and only when you are there it works out, and 24 bar 7 looking at it may or may not be very feasible. That's where there is many other modalities which we have. One of the modalities is the use of minimally invasive techniques where arterial pressure waveform is used to get an idea of what is the cardiac output. So one of the common ones which we have is by the Edwards flow track sensor, where you would get the idea in terms of cardiac output, SVRA. All these can be determined once you connect it to a platform. The other is by the Pulsion by Philips. This also can be utilized at bedside to get the cardiac output. Both of them are uncalibrated, and you get a value of both cardiac index and stroke volume. But there is always, whenever using uncalibrated techniques, the values may or may not be very reliable when the extremes of ages or patients who are very obese, lot of fluids. So that's where there's role for calibrated agents too. So this is an example of a thermodilation technique using PICO, where we have a central venous catheter where a cold saline will be injected, and this the thermistor will measure the temperature of the cold saline which is injected. Once injected, it activates, the fluid gets circulated, and you have a femoral catheter which has a thermistor at the tip which would measure the temperature change. Then you get the mean transit time over a period of time, how much time it took for the temperature change to reflect in the femoral artery. So based on the fixed principle, it is able to calculate the cardiac output, cardiac index, and depending on the body surface area, it will give you the cardiac index. So this is a little bit. This calibrated technique is much more reliable than uncalibrated. But in our ICUs, now how frequently can we do this kind of a technique? Or if the artery line is not patent for long duration of time, what other choices which we have? There are non-invasive techniques also available. This is based on the principle of pulse wave transit time, where the difference in after the pulse is generated to the time the pressure waveform is detected in the artery. This transit time can be utilized to calculate these values by stroke volume variation. In in studies, these values have been much more reliable and it is comparable to the gold standard. But so this can be readily used at bedside, and all it requires is a very good ECG and pulse oximeter waveform. As long as you get them, you will able to calculate the cardiac output. So this is available with the NIMHANS monitor in our ICU for bedside, and this can be utilized continuously. But the other option is to use bioreactants. So the Baxter, based on the bioreactants principle, electrodes which are placed on the chest, they measure the change in the electrical reactance across the four electrodes, which happens due to the blood flow which occurs across the aorta is what we commonly measure. And this change in the shift in the electrical signals, it is able to calibrate them into determining the cardiac output in terms of flow volume and cardiac output. This cardiac bioreactance has been better than bioimpedance in terms of influence of arrhythmias, fluid, chest fluid, and it gives a reliable value. And once you attach these electrodes, this can be left in position for the 4 to 5 days, and continuous recording of these can be utilized at bedside to make decisions. So these are the various techniques which we have. Now the question is this: whether you want the blue pill or the red pill. Now, there are various techniques depending on the your experience and availability in your institute. You can go for any of these, one of them. The main advantage of ultrasound is that you have it at the bedside. and you can utilize at any point of time as long as you have reasonable experience. So this is a common technique. The main limitation is it is intermittent, but it is very helpful to make decisions when you are resuscitating a patient in the initial phase, when you are anyway at the bedside with these patients. Thermodilution would be a better technique because it is calibrated, reliable, and continuous at bedside. And even if you are not there physically at the bedside, you can still continuous monitoring can be done, and changes in cardiac index can be identified and interpreted. Only thing is, a femoral arterial line has to be placed, and arrhythmias significantly influence the cardiac output measured by this technique. As later on, it also goes through utilizing the arterial pressure waveform in order to do the analysis. The third one, the use of minimally invasive techniques, the uncalibrated ones. The main advantage of them is that a commonly placed arterial line, you just connect to them and you get all the modalities which you need at bedside in order to make a decision. So this is the main advantage of this technique. But not never now the era has come where non-invasive techniques are coming off late to utilization at bedside. The main advantage of them being non-invasive, it can be used in the number of days, and it is not limited by the problems of the catheters which you place. The risk of infection is very less. The only thing is the signals has to be very reliable. The whatever non-invasive technique, the ECG electrodes or the chest electrodes, they have to get a very good signal. Then only you will be able to get a reliable recording from them. Now the question is, okay, we know what techniques we need to use, and we know the brain has various pathophysiology. Now the main thing is, okay, what do I do at bedside? So should I target blood pressure, or should I say, okay, I will maintain good cardiac output, forget the blood pressure? And if I say, okay, blood pressure I want to maintain, would I maintain systolic blood pressure or would I maintain mean arterial pressure? And if we do decide, okay, we will maintain one pressure, what would be the threshold which I would write it in my orders and say keep the blood pressure above this range? Now, this question is not so easy to answer because different pathologies have different impact of these things. Now, but what we have to remember is that if you take all these patients who are you have seen in any pathology, there would always be a blood pressure where the mortality or the outcomes are the best. So this is a U-shaped curve which any pathology is commonly seen. That means what the U-shape means is that once the blood pressure comes below a certain range, the mortality increases. Once the blood pressure goes above a certain range, then also the mortality increases. So when blood pressure, cerebral perfusion pressure, it's pressure. So optimal cerebral perfusion pressure is there for any patient which you see. And identifying this optimal blood pressure is where the understanding of the neurointensivist or the neurocritical care physician is very important to get the best outcomes for a patient. Now, these are from various guidelines for different commonly seen pathologies from our regular practice. So, if you see for traumatic brain injury, the guidelines say you maintain a systolic blood pressure above 120 and keep a cerebral perfusion blood pressure between 60 to 70. This is all it says, and this is the same throughout the duration, beginning from hours to days to weeks. You always try to maintain this as the goal. So you have both goals in TBI. That means you have a systolic pressure goal also, and you have a mean arterial pressure goal also to say we have to maintain a higher cerebral perfusion pressure. What about intracranial hemorrhage? In intracranial hemorrhage patients, initially the goal is to avoid increases in the blood pressure. So initial increase in the bleed. So you maintain a systolic blood pressure below 140 millimeters of mercury or at the level of around 140. After a few days, this pressure can be allowed to go up to 160 millimeters of mercury. This is what we want to do in intracranial hemorrhage patients. But these two groups of patients, again, everything is determined by how much ICP elevated it is in order to maintain which is the highest threshold you want to keep. Now, the scenario is little unique when it comes to subarachnoid hemorrhage and uh, acute ischemic stroke, because here the determinant of how much pressure you maintain is determined by whether the patient has secured the aneurysm in SAH or there is any recanalization which has already happened in terms of stroke. For subarachnoid hemorrhage, till the aneurysm is secured, the systolic blood pressure should be maintained less than 140, 160 millimeters of mercury is what is generally advised. And beyond, after the security of aneurysm, depending on which phase or how many days of victus it has been, then there is chance of providing permissive hypertension or treating for DCI. You maintain a mean arterial pressure of 100 to 130 millimeters of mercury. Or in our hospital, we commonly say, and our surgeon would say, keep a higher systolic blood pressure above 160. We give a lot of noradrenaline to maintain that blood pressure. But then here also, what is important is ICP. Sometimes when they have hydrocephalus, it doesn't, that pressure might be inadequate. That's why mean arterial pressure would be a better target. For stroke patients, initially, prior to recanalization, our goal is to reduce the systolic blood pressure and diastolic blood pressure so that we can uh, do thrombolysis. Once the thrombolysis is done, then the reasonable target would be to keep a systolic blood pressure below 185 and diastolic blood pressure below 100. But what you have to remember is that rapid reduction in blood pressure is never advised. Post recanalization, you can gradually reduce the blood pressure to normal. Try to avoid sudden drops in blood pressure. That would in itself worsen the ischemia which is happening to the brain. Now, till now, I have only spoken about how we maintain the intake. That means the delivery of blood and oxygen is what we have maintained. But our quest doesn't stop there. We have to determine but what we have given to the patient is adequate or not. That's where there is role for ICP, CPP, TCD, um, brain oxygenation, and microdialysis catheters at bedside. Now, why this is important is this because ICP is one of the important determinants in terms of, as I have already described, of how much cerebral perfusion pressure to keep. And the main advantage of doing ICP pressure monitoring is like our surgeons are very comfortable with doing ICP pressure monitoring because it is the oldest way of looking at the brain. And it is very simple. As long as you place a catheter, either an intraventricular or an interparenchymal catheter, you will get the cerebral uh, intercerebral pressure, intracranial pressure. And this intracranial pressure, it in itself can be treated to control and improve the cerebral perfusion. And also you can determine, you can modify your treatment in terms of administration of diuretics or administration of propofol or barbiturates or even titrating therapy like decompensating. Timely intervention is much more easier to do because the technology is much more simpler and understanding of people is much easier for using intracranial pressure. The other advantage of other non-invasive technique which we can use at bedside to look at cerebral blood flow is transcranial Doppler, where through a transtemporal window we can insonate the middle cerebral artery in order to get the cerebral blood velocities. Now, the main disadvantage or limitation is that it requires certain expertise and training in order to learn it like any ultrasound-based technique. But once it is done, this technique can be rapidly used at bedside, non-invasively at any point of time in order to continue to measure. And because it's a very common technique, there are a lot of normative data and pathological data which is available for us to guide treatment, like in terms of subarachnoid hemorrhage, determine whether vasospasm is there or not, to differentiate it from hyperemia. Or in other, it can also be utilized to determine the prognosis of a patient in terms of like brain death, to say whether the cerebral blood flow is worsened, like by having a reversal of flow or only systolic spikes being seen. But one of the best ways at bedside to look at adequacy of cerebral oxygenation is to look at brain oxygenation monitors. Uh, Two of them which we use in our institute commonly is the use of jugular venous oximetry, where a catheter is placed into the jugular bulb. This catheter, uh, we have a catheter which comes uh, where we are able to determine continuously the venous oxygen saturation. Once you place this catheter, this can give an idea of the global oxygenation status of the brain. The other which we have is the use of near infrared spectroscopy by placing in the frontal forehead. For a limited amount of cortical tissue, we are able to look at the cerebral uh, uh, oxygenation, regional oxygen saturation. But the main limitation of this use of NIRS is that it is determined, it has a lot of extracranial contamination which would make this value variable. And also whether the skull bone thickness, the amount of edema, and if surgery is done in the frontal area, then the utilization of this technique is much more difficult. But then this is more of a trend monitor. So rather than looking at the absolute value, saying that if the value is less than 55, I am going to treat it, it is better to look at the trend. Like if you have a consistent value of 65 to 70 for a patient and it rapidly fell down to 50 to 55, then you have to look at any acute changes in the brain which could have happened. Whereas jugular oximetry is much more straightforward, where you try to, but it's a global monitor. It would only look at the main importance is to at bedside whether the hyperemic status or is there an ischemia, it can be determined. Microdialysis is a newer technique where it directly looked at the metabolic parameters by the level of glutamate, pyruvate, lactate in the brain. And this in itself can determine whether the perfusion is good or not. You place this microdialysis catheter right next to the penumbral area where the brain, where our area of interest is, to ensure that the brain of that area survive. But the main problem is it's invasive and it's not available everywhere, and the cost of doing it has limited its application. Now, this is from one of the surveys which are conducted and published. So, which are the different monitors and how much they have been used at bedside in various areas? The commonly used one, like I said, is ICP because it is relatively simple, everyone understands it, and this is a very easy measure to convince our neurosurgeon to place at bedside. Despite of the risk of infection in a severe critically injured neurocritical care patient, this is a common go-to modality in order for us to know how the brain is there at the bedside. Next common one is the use of EEG. But then the main problem with EEG is that unless you know how to assess it, it becomes very difficult to interpret. And titrating therapy would be difficult in terms of using EEG. There is a role for TCD, and the predominant role has been in the use in subarachnoid hemorrhage patients where it is useful to titrate vasospasm therapy at bedside. There have been sufficient use of brain oxygenation parameters also, where NIRS and PBT-O2 has been used. For a minor case, cerebral metabolic dials catheter and pressure reactivity index can also be used at bedside. Pressure reactivity index in itself is a separate large topic, so I will not go through that at this point of time. Now, how much do we maintain, or what kind of normal in our ICU? What would be our hemodynamic targets for different groups of patients? Now, it is cardiac index of 3 to 5 liters per minute would be an ideal target, and global for a preload and endostolic index of 680 to 800 ml would be an ideal target. For fluid responsiveness, keeping it whenever the SPV is more than 100 or PV is more than 13, then that means they are responders. And for looking at pulmonary edema, you can always look at ultrasound to look at the A lines in them. So these are the targets which you have at bedside. Trying to maintain them would be ideal. And there are phases where you see there's been deterioration in a patient in terms of clinical deterioration, or any of your parameters like ICP is high, oxygenation value has been come down, or a TCD is showing a lower blood flow. Then we need to, before we are able to diagnose in terms of doing a CT scan to look at what is happening inside the brain, we need to immediately optimize that pressure. So that's when there is a role for hemodynamic augmentation. We don't know what is the pathology in the brain which has caused that dip in the neuroparameter, but we need to augment. So that time we can do a normovolemic augmentation by increasing the blood pressure by administering any of these agents, noradrenaline, dopamine. And after increase, then you can always observe by the time you get a more any correctable cause not find it by doing a radiological examination, you can increase the blood pressure to see for response whether it is improving. So sometimes only administration of norepinephrine is inadequate. You also have to optimize the preload and any fluid responsiveness. If they are responding, then you have to administer more fluid. Sometimes when you do these advanced monitors, you would see a very low cardiac index. Then we need to do what is called as a cardiac output augmentation. As of now, there is no clear cut what you say target only blood pressure or target only cardiac index as such a recommendation like that. It is always depending on which patient which you are treating. It has to be individualized to them. If somebody has a normal blood pressure, very low cardiac output is low, a high blood pressure might be there because of a very strong systemic vascular resistance. In them, there might be need to improve the cardiac output if your end organ perfusion factors like lactate plus are low. Whereas some patients don't improve with only noradrenaline and cardiac output is low. That time you need to add additional dobutamine might be required. So it is very difficult to generate a recommendation where you say always target cardiac output or only blood pressure. You have to look at them both in order to maintain a good perfusion for a given patient. So whenever you are managing these patients at bedside, you need to know the diagnosis which you have in order to know what is your target or what kind of therapy we need to give. And whenever you give any kind of therapy, always you have to monitor them clinically, hemodynamically, or in our case, you do cerebral monitoring. You initiate whatever supportive therapy which you need in order to optimize them. Always go back whether the what pathophysiology, whether it is remain the same. Do my targets or therapeutic guidelines or whatever therapeutic thresholds which I have kept need to be changed. You need to always revisit them in a circle, and this is where it is important at bedside to apply this knowledge. So I have an example of for SH how a flow track can be utilized at bedside for optimizing the hemodynamic status for a patient. So initially, if somebody has a lower pressure than which you would need, you want to increase the blood pressure, then you look at first thing you look at is whether the patient is fluid responsive or not. So you look at pulse pressure variation or stroke volume variation. If it is less than 13%, then if it is more than 13%, then you give a fluid bolus. If it is less than 13%, that means the fluid status is adequate. Then you look at the mean arterial pressure, if it is high or low. If it is low, then you look at cardiac index. If the cardiac index is less, then it would indicate need for a positive inotropic agent. If the cardiac index is low and the SVRI is, if the cardiac index is good, but the SVRI is low, then we need to start a vasopressor. So this is a very simplified form of using goal-directed therapy in the management of to optimize the blood pressure. Now, for us, these are the three most commonly challenging patients at bedside in the ICU. One of the important ones is the TBI patient suffering from hypotension. So, the common reason for a TBI patient to suffer hypotension initially would be blood loss, inadequate fluid volume. So, preload optimization of preload would be the main target in terms of patients when you treat for TBI. For subarachnoid hemorrhage, the most common problems which would result in difficulty for us is when they have a cardiac compromise along with because of the disease. So in this group of patients, for us, optimization of cardiac index becomes a very important target, where utilization of any of the parameters which we have done to optimize cardiac index would be the goal. Third is stroke, any kind of hemorrhagic or ischemic stroke. The main problem with these patients are that they are elderly patients whose cardiopulmonary reserve would be limited, or they might have a secondary comorbid illness of the heart where they can have ischemic heart disease, post CABG status, with or without a low ejection fraction. So in these patients, despite of a normal blood pressure, or they are more likely to have hypertension, and control of this hypertension, you also need to do cardiac output monitoring of or any bedside monitoring techniques in order to optimize their perfusion status. So these are the common challenging patients which we have in the hospital. The other challenge which TBI patient other than hypertension is that after the first week, they develop autonomic dysfunction in terms of severe hypertension. Then the need for alpha 2 agonists are all important in this group of patients. But then they are not as severe as in the initial stages, where inadequate management of any of them in the beginning stage would result in a lot of brain injury, which may or may not, which may cause irreparable damage in them. So this is one of the protocols which is published in stroke, where to keep a mean arterial pressure goal, where they have used cardiac output monitoring in subarachnoid hemorrhage patients. If the mean arterial pressure is up to the goal, then you look at the global end diastolic volume index as a marker of preload. If it is low, then you need to give fluid. If the global index is good, then you look at cardiac index. If it is low, then you start dobutamine. If it is good, then you don't need to do anything. Whereas if the MAP goal is not reached, then also it remains the same. You look at end diastolic index. If end diastolic index is low, then you start with fluids. If the end diastolic index and this is extravascular lung water. If this is low, then we need to give fluids. If the preload is good and contractility is also good, then we start noradrenaline to titrate the blood pressure to mean arterial pressure. So what you have to remember is whenever you look at patients to optimize any mean arterial pressure, first thing you look at is the preload. Any way of looking at preload by ultrasound or using SVV, PV or PPV, you look at it and then see if the preload is adequate. If preload is adequate, then you look at contractility. If contractility is good, then we will need to put vasopressors. If the contractility is poor, then we need to add a dobutamine inotropic agent, like dobutamine on bilrinone in order to improve the venous arterial pressure. This is what we need to remember at bedside. And use of this early goal directed therapy have definitely had good outcomes. Some studies have showed lower vasospasm, some studies have showed good cognitive outcome, and even reduced incidence of hypotension and cardiac index. Now, how has the practices been in SAH patients? If you see, the most common modality, because these patients do would have undergone some surgery or procedure, arterial blood pressure is the common way of managing these patients. The second, and at bedside, because central venous catheters are commonly used for them in order to titrate, give them because they are there for longer duration of time. CVP also has been monitored a lot, and volume status determination, fluid responsiveness, and lactic acid monitoring. These are the common ones which are done at bedside. And SVO2, that is central venous oxygen saturation, to look at adequacy of cardiac output has been done. But the use of at least cardiac index is much lower than the use with arterial blood pressure, because not every patient would require. Only the patients who are severely compromised would require a cardiac index monitoring in order to maintain the blood pressure. But the ratio of use of advanced cardiac hemodynamic parameters like endosteric volume or extravascular lung water is still low. PA catheter use is very less. Whereas if you see monitoring techniques, the commonly used monitoring technique, as I told, is ICP. Then TCD use is really good. And use of the other important point in neuro SAH patient is the radiology. So whenever these patients do go for DSA, you look at the venous transit time, how much of vasospasm is there. This also is a very important marker at bedside for us to make decisions in SAH patients in order to how much pressure we need to maintain. If there is a lot of vasospasm on SAH, then we need to have very high, good blood pressure. If the vasospasm is much relieved, then you need not target temperature, blood pressure of 160. At this point of time, it is important to note that just increasing the blood pressure to maintain a certain amount of cerebral blood flow is not the only thing. We also have to remember there is some adverse effects also when you do this hemodynamic augmentation. There are many studies which have evidence. That's why it is not a uniform recommendation, or there is still no class 1 recommendation for hemodynamic augmentation, because this hemodynamic augmentation in itself can lead to many systemic complications like ARDS, pulmonary edema can happen. So that's what we have to keep in mind. And also use a radiological parameter at bedside. TCD is commonly utilized. And among the various modes of volume status assessment, a commonly used one is the use of arterial waveform analysis, SVO2, like administrations like central venous catheter oxygen saturation, and ultrasound at bedside can be utilized. Now, TBI, when you are using TBI, this is one of the studies which we have done, how the cardiac index changes when these patients undergo surgery. So the main thing is, whenever they undergo before surgery, there is always a sympathetic hyperdrive which is there. The high sympathetic hyperdrive will have a very high SVRA. What we have noticed is that these patients, rather than suffering from a low cardiac output state, they have a very high cardiac output state, severe the brain injury. And once the brain is decompressed, the cardiac output improves by the decrease in the SVRA. This is what we have seen. And in our study of around 107 patients, what we have noticed is that patients who have a normal cardiac index or slightly lower cardiac index, they had performed better at discharge than patients who had a very high cardiac index. So that means that in TBI patients, targeting a very high cardiac index, patients who have very high cardiac index, they have poorer outcome than patients who have a normal cardiac index. This is what. And the pathology also, for a patient who has a bleed, for him, once the hematoma is evacuated, he doesn't require a very high blood pressure, because now the brain is lax. In him, a normal blood pressure, mean arterial pressure, CPP, would be much easier to target. Whereas patients who have much more diffuse injury, like diffuse axonal injury, diffuse cerebral edema, these patients are much more tough, because here it is very important for us to know what the ICP is and what cerebral perfusion which I am keeping is adequate or not. So this kind of patients are more important for us to, in order to determine whether what we are maintaining is adequate or not. So TBI management as of now is centered around optimizing the cerebral perfusion pressure and reducing the ICP. So in contrast to the SH, if you see, the use of ICP is much higher in them. other monitors, TCD and all, are much lower. ICP becomes the most important monitor which we do in TBI. And the use of arterial line here also is high because most of them do are in the critical stage where they require continuous arterial blood pressure. And the other important state is the use of volume status, fluid response. These are also much higher because they lose a lot in the beginning, either because of injury, surgery, or because of the use of diuretics which we use. There can be a lot of volume status fluctuation where the assessment of fluid responsiveness is very important. And that's where the use of invasive monitoring and ensuring that the end organ perfusion is good is also very important, where there is still a role for jugular venous oxygen saturation or brain tissue oxygen saturation in this group of patients. So, just to conclude what we are telling this that the main limitation is this: we need to believe in these principles, use these monitors at bedside. Only then these will reduce the duration of stay in our ICU. And also, we need to understand what variables you are using and what are each of these limitations in order to effectively use them at bedside. So always remember that each injured brain, depending on what physiological state it is at, the optimal CPP will be different. And using hemodynamic monitoring, we can individually target each of the components in terms of preload, afterload, or contractility, and optimize them to have the best hemodynamic state for a given patient. As of now, blood pressure and cardiac index, looking at both of them would make more sense than looking at only one of them. And target change them according to the patient status to reduce the amount of complications. And the best patient in whom this would be useful is severe traumatic brain injury in the initial phase, poor grade SAH patients who are presenting with the stage where they are vasospasm or in early brain injury, or any cardiovascular complications are there in the patient. In these patients, it is very essential for you to think about use of multiple hemodynamic monitors in order to get a better idea of them. Thank you. Uh,
Thank you, sir. Thank you so much for this wonderful presentation. So, for especially in a subarachnoid hemorrhage, it's a very dynamic process. So, when we even put a cardiac output monitor, we have to remember that the patient's condition is very dynamic, and the patient condition, even though it may be fluid responsive initially, it can go towards what do you say? The patient might be actually requiring inotropic support rather than just fluids. So it's very important to administer cardiac output monitoring at that point to individualize the patient's therapy. Sir, I would just like to ask you what would be the role of IABP in managing or optimizing the hemodynamic status in neurocritical care patients?
Sindhu, to realistically say, I have not used IABP, but there has been multiple times where we have come across patients where we run out of choices to do have. Like you already placed hemodynamic, you already started them on noradrenaline, these, but still you are not able to optimize their cardiac output. I mean, they are not at a stage where you are saying the patient already has severe head injury, prognosis is very poor. It's not at that stage. In acute injury phase, especially elderly patients, where they have some cardiovascular complication, where the heart is not able to compensate or improve the cardiac output to an extent which you would want it. Maybe then there is a role for use of IABP in that particular group of patient where you are not able to optimize cardiac output, and you would see that there is definitely benefit of utilizing it, and which benefit is outweighing the risks of IABP in that particular group. In them, if you have the setup where you have a cardiologist who is willing to help you out, then I think it is fair enough to utilize it at that point of time.
Recently, we had a case. The patient had a malignant MC infarct. He underwent a decompressive craniectomy, and we also found out that he had a triple vessel disease because we did the angiogram. And the patient's cardiac index was very, very low. We gave milrinone, we gave dobutamine, name it. And then the last thing we asked the cardiologist was the IABP. But then he also was like, not going to help him much. So for that patient, even that was not tried, and he succumbed. So for one more patient, we did use IABP, but even at that patient succumbed. So the
The
BP kind
thing
of
is,
didn't improve at all.
I think, like you said, once somebody determines that prognosis is poor, they look at the brain
Yes,
scan
sir.
and they say prognosis
Yes,
is
sir.
poor. That becomes
Yes.
a very important
Very important factor.
determinant for us what kind of decision we need to make.
Right, sir.
But
Right.
then, as long as the patient is salvageable, that's why, like you said, early intervention, like maybe the speed at which we work at, you are not able to optimize the patient's dynamics
Yes, sir.
within the first 1 hour. Maybe that's when you can take the decision to see if IBP is feasible or not. Maybe then you would be able to convince the neurosurgeon and cardiologist to place it for a given patient to benefit.
All right, sir. Thank you so much, sir. Thank you for this wonderful discussion. We'll meet up for the next classroom series. Thank you, everyone.
Thank you. Thank you, everyone.
Thank you. Thank you.